Alexis, if you could just put up that last slide for me, please. I think that we have a variety of different perspectives here today, so we should have a great conversation. But I think that we also need to really look at all of the places where we can insert health literacy in a meaningful way. And this last slide here, that I can see, but I guess you can't see yet. Really, I think it brings it home for me. It's the label and the package inserts are so confusing to people, but we can't wait until it's recruitment time or informed consent time to do something about this. We need to start earlier in the process when we're looking at what types of variables or patient-reported outcomes we're actually using in the trials, and make sure that we have potential patients or people who have the disease that we're looking at involved in this language early on, so that we're asking questions that we know they understand and we're getting the right answers. And then when we put those labels and packet inserts together, they're already in a health literate format that patients helped us devise, so they already understand it and it's not so confusing. So I think that while here we're talking about starting at recruitment and early, there's even earlier that we can be involved. So I think we all need to think about that. The other question that I would like to address to our panelists before we go around and ask everyone questions, we all share best practices, and we're all very involved with incorporating health literacy into our work, but what often gets lost is the failures, and I think there's a lot that we can learn from that. So I'm wondering if any of the panelists have any examples where, with all your best intentions, you tried something for clinical trials, whether it be recruitment materials, informed consent, that didn't work out, and what did you learn from that? I know as an investigator on the Women's Health Initiative, we tried many different things to recruit patients into the trial, and this trial especially, the patients or participants were not going to necessarily gain from that themselves, but they were going to help the next generation. So it was a very altruistic way of doing it, and we tried multiple ways, having videos before the informed consent that people could understand, so that went along with the informed consent. We also found that for each of the different groups we were looking at, as Ebony mentioned, we needed to use different strategies. So for some, we went to the pastors of their churches, for example, in the African American churches, and had the pastors invite them to come in, and then once they were in the trials, encourage them to stay in the trials. For others, we went to senior centers and had lunch with people and sat down. We had a coalition from the community where volunteers were actually members of the community, and they went and recruited their own people and explained, because I think the piece we didn't talk about today so much was the emotion that's involved as well in participating in clinical trials. And no matter how health literate you make materials, if you don't take those emotions and background history into account, that's not going to be as effective as it is. So I'd like to ask any panelists if they have anything that didn't work that you learned from in terms of recruitment or informed consent or summaries at the end. Anyone?
I'll speak to it as a generalized failure as opposed to a specific failure, because this has happened over and over and over again. But when a few years ago, working for a company that was looking to match patients to clinical trials based on genomic information of the actual tumor profile of their cancer, the assumption was you can put messaging sort of on blast. You can create one message, put it on blast either on social media or in print or radio or the web, and that should take care of you should just fill your funnel, and all these patients will magically like fall out in the bottom and be magically recruited and enrolled in a clinical trial. And I think that the quickest thing that we learned from that process was it's about health literacy, it's about tech literacy, and cultural literacy. That you can't create one single message that works for everybody, and you have to be willing to be agile and flexible around your messaging, and you need to be able to create a feedback loop in your recruitment and engagement process that allows for learnings as you step into new communities for the very first time. Those communities are going to tell you what works and what doesn't work, and if you're not responding in kind with the right message, you've violated the trust and respect that you step into that community with. And I think that the biggest lesson that I learned from that is before you even begin building your messaging, work with the communities that you want to recruit from, that you need to recruit from, and be willing to be flexible in your messaging and your approach, because what might work for consumer marketing doesn't necessarily work for quote unquote clinical trial marketing. And I think that there's been an over-reliance on general marketing principles that we feel we can borrow from consumer marketing and put into clinical trial marketing, and it doesn't work that way. We shouldn't even be calling it marketing. It's relationship building with communities that need help and need care and need new treatment options. And until we sort of make that change, that paradigm shift in the way that we approach communication with our communities, I think that we'll be continually having these generalized failures across the spectrum. So it's being culturally competent in a way that we've never even considered before.
Thank you very much. Katina?
So, I think the messaging is so important. I agree with every little thing you said. But the other piece I would say is it's more than messaging. We did an interesting study before I was in health literacy when I was back at Washington University, and we were doing community engaged research through community sites. And we had some funding to create a really fancy database with algorithms to enroll people from communities, match them to open trials, and deliver them to the site of a trial they matched for and they were interested in, right? Seems like a no-brainer. People qualify, they want to do it, you take them to the door. Still couldn't get them enrolled because the investigators couldn't figure out how to do it with community folks that they didn't feel certain they had enough contacts for to get them back, and all of this drama around the actual logistics on the university side. So this goes back to the two-sided situation. You can get people there all day long, and they are excited, and they are ready, and they are geared up, and they still sometimes don't make it to enrollment, to participation, to completion. And I think that's really a complicated thing. We were so sad, but then we also use that to figure out some other messages, right? So there are other ways to do that. And I think what I would also say in the generic response to this is, best I can tell across studies is the first approach to recruitment almost always fails with somebody, right? We spend our whole time trying to figure out how to meet the goal, get the people, make sure that we have enough diversity and representation, and how do we know that at the end of the day, we're going to answer the question that we really have. And that iterative process to make sure that we keep getting the right people and they stay engaged is never right the first time. And so I think that flexibility and curiosity and collaboration with the folks that you're trying to reach is really the gold standard.
Thank you. Chris?
I'll give you a specific example in a second, but I would venture to say that every time I've user tested a document that I've written, I've learned something. And I've been doing this for 15 years, in various contexts, in the legal context and then the health literacy context, the last 7 or so. Because even though I'm kind of, plain language and kind of clarity and health literacy kind of runs through my soul, there's still going to be this curse of knowledge that you have that sometimes you just don't see it from the other lens. So I learn all the time. So one example of this, I was helping create a couple of years ago a hospital kind of transparency website for a hospital association. So people can go on the website and kind of compare safety metrics at various hospitals and those type of things. And so I was really excited about this speedometer that we were going to use. 89%, we'd have the speedometer go up to 89. Well, we tested it with folks, and they're like, is that bad or good? Because if you speed, it's bad. And I was like, oh my gosh, I never thought of it like that. I was thinking, all right, now you know. And so we changed that around. But But that's just one of the examples when you mentioned that it popped right in my head because I thought, oh, this is going to be pretty cool because people get the speedometer concept, but I never really thought about it from that perspective because speeding's bad. Right? So.
Thank you. Ebony?
I just might say that I've had extensive experience in testing out people's understanding of information that they're given about their condition, and spent a year developing some materials for people with kidney disease. And somebody commented on this earlier, that it's not just even the words, it's the numbers, and numeracy as well, and how you depict pictures. And, just to even help people understand what's the difference between a small effect, a medium-sized effect, and a large effect. I mean, we spend a lot of time trying to figure out how to tell people that there's a big difference in something versus a small difference. And we're even thinking about, well, how do people think about French fries, small, medium, large, or, how do people think about magnitudes, quantities, and this information? It's very, very complicated, and I think we're just still at the early phases of trying to help people really understand all this complicated information. So I do think user testing, this is a constant thing. I've never also put a document out there that didn't need at least 10 iterations to improve it, and wasn't perfect at the end either. So I think this is just an evolving, we're all constantly undergoing those failures, quote unquote.
Thank you. I think these are important issues. The numeracy piece is very hard to grasp. And if we follow the AHRQ recommendations of universal precautions, we would be assuming that 80 to 90% of the people we deal with don't have the health literacy necessary to manage their disease. And that's very evident when a study like the one I was on, the Women's Health Initiative, the news breaks and it's out in the newspaper and they're reporting relative risk, which sound really shocking. But if you have an event that's 1 in a million and you double hit, it's 2 in a million still, but that's the absolute risk. So at Pfizer, we've put out an interactive infographic that actually talks in terms that we hope people understand about, and Alicia helped us with this, absolute risk versus relative risk, and what types of risk would you be willing to take compared to the risk you take crossing the street or getting in an airplane, for example. So I think putting it all into context is really important. So what I would like to do is take some questions from members of the roundtable, and then if we have more time, members of the audience as well. I'd ask you to please, I see you already have a lot of cards turned up, and also use your microphones when you speak and introduce yourselves. So I didn't pay attention who was first, so I'm going to come this way. So I'll take your.
Elaine Caixinha Waller, University of Wisconsin-Madison School of Pharmacy. I really appreciated all your presentations, especially Dr. Boulue. I really appreciate, especially as an investigator who does a lot of educational behavioral interventions, I really appreciated seeing that there is a lot of work that has been done into putting minorities into this research. The question I had was, we've spent a lot of time talking about strategies for recruitment and retention, and I wanted to know a little bit more about the dissemination of results at the end of the clinical trial, and what are some other strategies that we could use? I know, Katina, you talked about clinical trials, the summaries, but what if that doesn't work for people? What other strategies can we think about? What about people who have reading difficulties? I might not even be able to read those summaries. And so I wondered if any of you had other insights on the end of the intervention in, giving that information back.
So I think that there's a focus on the lay summary, as it's termed right now, because it's a requirement. If a trial has, if it's being conducted in certain parts of the world, and because of the interconnectedness in some of the large trials, there are sites all over the place. And so that's just a requirement that people are preparing for the trials that have to be reported, and it's happening here in the US. And so I don't think that for a lot of people, these lay summaries are the best approach to getting information back out to them, but it's the required approach. I also don't think it's bad. I think it is important that people have a piece of paper that's readable, that they can grab from online or they can get at their doctor's office. I think it's a really good support to conversation and understanding, and it's an easy checkbox to say, we mailed it to everybody and they got it. So at a start, it's a good sort of basic assumption that at a minimum, we can hand them a piece of paper. But in community-based research, and I know a lot of people here in the room do this, there are attempts to sort of go back and get your initial groups together in the community and have dissemination meetings where you talk with them about what happened and you use that as the opportunity to think about what's next and what was missing. And there are people that include research participants in discussions about how they write up papers, and they write those sort of versions that are the public, scientific go on your CV version, and then the version that maybe goes in the newspaper or the newsletter from a neighborhood, or some other versions that are more public facing. I think people really like those. I hear from participants that they think that's really cool. I think some of the other advocates in the room could probably talk about how they want to be engaged all the way through the process, and that includes deciding at the end how we talk about this. Video is always great. It's just so expensive, and what we find is that people don't have a lot of money on the back end to pay for complicated production. So you have to figure out sort of what your investment is going to be. And is it worth more to you to have a video that everybody can see, or a deep engagement with a smaller group? I think those are all choices that reflect sort of philosophy and values and connection with communities.
I know one of the things that we're working on at Duke is developing an information portal where study participants can actually they can log in at the beginning, and that they have a constant communication with investigative teams throughout the entire journey, and then can also receive information. This would, of course, require that the person have some access to some technology, but that is one approach that we're developing right now to enhance the kind of communication throughout and including at the end of the study.
What we've done for particularly vulnerable populations is we've actually had small group sessions at the end, like a tea, where they would come and have some snacks and meet with others who had participated in the trial, and we would have a presentation and explain the results, and then the investigators would be there to speak with them individually if they wanted. Obviously, everybody can't do that, but it was really powerful and impactful to do this, and we've done it several times. Okay. Michael, you had a question?
Two comments, actually. So it's interesting we haven't brought up the ARC Informed Consent Toolkit, and maybe it's, I know Cindy is, if she's not on the webinar, I don't think she's in the audience, but that did come out just as a local perspective to share. Rebecca Sidori, who's at UC San Francisco, and many of us know her here, she's done some great work. We partnered with her years ago on studying the value of the Informed Consent Toolkit that ARC had put out. And the first thing, just to comment on, we did a large study that we had an existing trial, and it almost killed the study when we tried to implement the ARC Informed Toolkit at the beginning in its current form, because it was this idea that you have to bombard and make sure that the consent process, which a lot of patients, and I would probably make the argument lower health literate patients, will just naturally be inclined to agree to participate in many instances, especially if there's a financial incentive and they don't want 20 minutes to be consented into a study. That said, incorporating factors like teach back and whatnot, we were able to show with Rebecca's work that we actually were able to improve retention of information, so they were more knowledgeable about the study. They had less decisional regret in participating in a fairly invasive study after the fact, and so there were some benefits if you could just mitigate the impact. But a lot of that required spoken communication, because a lot of the written materials, kind of the other thing I think the health literacy evidence that we've shown is that no matter how good the written material is, it will not do anything for people with the lowest levels of health literacy. They just can't read very, very well, and they're not going to utilize it. So finding alternative ways that through spoken communication, through video, and allowing, again, the ability for us to have that approved and not have the same old expectations, I think is important. My last comment also is in putting more attention to the retention aspect. A colleague of ours at Northwestern, Laura Curtis, had presented this in a meta-analysis of about 8 studies that health literate patients are also more likely across studies, whether they're clinical trials or observational studies, they're more likely to not be retained, significantly more likely, which actually puts a huge skew to a lot of the scientific evidence we even know about these groups. So I'm still trying to figure out what exactly we do about it that's beyond an informational solution, whether it be incentives, ways to make sure that those individuals, especially in health system type interventions, that those individuals aren't marginalized.
Thank you. Does anyone want to comment on that?
I would just comment that my work before I came to health literacy was HIV prevention with drug abusing women, and we saw that all over the place, that we lost people sort of left and right for a lot of reasons. And the way that we found people again were the things that Dr. Buller talked about, like going out to their house. You know, I would call and say, you know, this is Katina, I haven't seen you in, 16 months, and your information is really important to me. I want to know how you're doing and how this worked for you. Do you mind if I drop by? And nobody ever told me no, right? They were always so happy when I would show up at their house, and they would bring out tea and drinks. And I mean, it was like a really big deal that somebody cared enough to come to their house. And then they would call back for the next one. They would never miss a follow-up again after that. And so much so that I kept the same phone number for about 14 years. Including when I wasn't doing this work anymore at WashU, because people would call and say things like, oh gosh, I was in a study a long time ago and it was really great. I just wonder what you guys are doing now, because, I'm still having trouble and whatever. And so like that effort to connect is so meaningful and transformational for people that I think, we should figure out how to do it more. The hard part is it's hard to figure out how to build in enough funding to cover it all the way through. It's hard to predict how many people. I think that a lot of studies just don't have the support to keep that going. And not everybody can do it, right? So the people that do your interviews can't all, hop in their car or hop on the bus and go out to people's houses. It's a pretty specific comfort zone.
I'd just like to add one thing that I see from the patient perspective is a lot of the clinical trials are very specific. It's like everybody gears up for one trial at a time. And this group is working on clinical trial A, this group is working on clinical trial B. They're all recruiting from the same populations, but they're very individualistic in the way that they're reaching out to the community. And I feel like if there was a way, and I know that this is a pipe dream, high level thinking, but if there was a way for more industry collaboration around therapeutic areas or disease states where you're working for the collective good, educating the community, not only about clinical trials, but just health in general. I feel like a lot of the efforts that I've worked on over the last 10 years have been very, very specific moment in time kind of, we've got to recruit for this trial right now, or we need to go after this community or this population. And I always feel like I'm like getting dragged into the quicksand, so to speak, because I feel like I'm like, wait. If we step back and educate the breast cancer community about why this is important, not only for this very specific trial, but advancing clinical research as a whole. I just feel like if there's a way to build more collaboration in at a level that not only works for industry, but the patient populations that we're trying to reach, we do a much better service for everyone just in general. I feel like we overcompensate when we're missing a population or an ethnicity, what are the people that you're going after, or how are you trying to recruit into these different communities? And I feel like we spend too much time going after the minutia of the clinical trial and not more about the actual community building. To me, clinical trials is about a relationship building exercise with communities that have to start before and continue during and continue after the clinical trial is over. It can't just be a one and done proposition. And I feel like we spend so much time, money, and energy on the recruitment side that we forget, like I think you just said, there's no money left at the end of the trial to properly talk about what worked and what didn't work, and where's your after action review? How do we take that to the next step? And we'll get there. somehow.
And I'll just say regarding the consent, I couldn't agree with you more. You know, consent is a memorialization of the education that should have went on, not just a transactional document at the end that you just sign. But that's how it's evolved, you know, over time, is it's more proof. That's how we think of it. It's proof that you agreed to this. It's not proof that you understood anything. It's not proof of anything else. And so that's where I think kind of the mental shift that the common rule is supporting is, you know, how do you best facilitate understanding? Not just how do you best facilitate how to prove this if they say, you know, there's a problem, you know, down the road a ways. And so, so I couldn't agree with you more. It's not just the written form. It's this whole teach back process. It's the educational process. It's planning everything that you're going to do to recruit and retain and get people to, you know, get people through the whole process, not just the consenting process and then you forget about it.
I would echo all those comments. The one thing I'm thinking about with regard to this sort of retention issue is like the understanding, I think, is critical. And I think there's this big race to get the signature on the piece of paper that the person agreed to do the trial. But we should really be thinking about, do these consent processes need to be broken up into multiple pieces? Do we need to ensure a person understands Part A before they can get to Part B, before they can get to Part C? And then, you know, the chances of the decisional regret at the end are much lower when the person has had time to really digest. What does it mean for me to participate in this study? I think that's another tension, is that the time it takes, you know, as an investigative community, we really have to take that on as to what we're willing to do to really ensure people understand what they're doing rather than just sign on the dotted line.
Thank you. Consuelo?
Consuelo Wilkins, Vanderbilt, and Meharry. A quick comment and then a question. So I think, Chris, you talked about reasonable person. I just want to caution the use of that language. And I'm sure you've thought a lot about it being, you know, a lawyer. But for me, hearing reasonable person and thinking about the people that I'm most interested in making sure they're at the table, from a reasonable person is from the standpoint of people who have power and privilege. And if we try and put all those people who don't have power and privilege in that reasonable person or people category, then we're missing them. So I think in the standpoint of clinical trials in particular, I do think we have to be careful using that kind of term. And that's not, you know, just you, this is just in general. My question, though, is really a follow-up of Ebony's point. So I spend a fair amount of my time talking about engagement with clinical trialists across the country. And most of them think it's a great idea to engage and make sure that people understand. But when it's time to actually do the clinical trial, they're worried about speed, efficiency, and costs. So if we really want to make a case for more health literate information and engaging the patients and participants, we really have to have measures and metrics that are going to resonate with them. And I think that's the actuality of it. So if we're only looking at recruitment and retention, those are certainly very important. Those are issues. But I think what I'm hearing you all say is that we should be thinking about other measures and metrics, patient experience. And so if you have any ideas, if you've used any, I think that would be helpful for us to know or think about how you're capturing these measures, and are they being used across different trials. I certainly have seen some measures around engagement, especially in some of the industry trials with, you know, time to IRB approval when you engage participants, the dollars saved from not having to have multiple protocols reviewed. So I'm just wondering if there's any experience based specifically on health literacy.
Well, I'll just comment on the reasonable person thing. But you're absolutely right. That is a hedge that the law has created over time because they realize they can't, you know, figure out every single situation. It's not the subjectivity of it. But that is the real concern, and it has been my concern in the law for a long period of time. You know, in consent in a non-research world, the reasonable person standard applies in about half the states. The problem is that standard has been, like you said, developed, you know, for privileged folks, privileged judges, privileged juries. That's how this standard developed over time. So what I think we can use this as a health literacy community is now, at least within our study populations, we have some research showing who reasonable people are. They're not these privileged folks with education from X degree or university or whatever. So we can hopefully rein it back in, because I don't think we're going to, from a legal standpoint, I don't think we're going to be able to, the legal standard is all kind of how can we couch or fit the majority of folks, not the people on the margins. And there's always going to be people who are marginalized. But I was a little skeptical when I saw that in the guidance, but I think it's probably rational. It's got a rational decision to do this, but this is where I think we can help shape that narrative of who's reasonable and how broad do we look at it. We should look at it in our study population, and then that hopefully will bring in, minimize that so we can look at what the characteristics are of each person. So, but that is definitely an amorphous concept that's difficult.
Thank you. Steve, you gave up on your question?
No, my question really had to do with this concept of the reasonable person and thinking about the context, because everyone's really brought up this idea of the context. And I think that's a really important piece. And so if we're doing the law, the rule to help organizational change is, it's good, it's consistent with the law of the reasonable person, but I'm also thinking that the context is really different. Because if I'm going to do something to save myself and maybe others by going through this clinical trial, then certainly that would be something. The concept of reasonable person is really interesting because it's in this uniform glossary where they talk about this reasonable person going to an emergency room. And then I've just thought about the reasonable person going to the emergency room and then health insurers denying payment for going to the emergency room to find out something that might or might not really be an emergency from a reasonable person standpoint. So no, I didn't give up, but it was addressed. Thank you.
Okay, thank you. You have a question?
Perfect. You gave me the forum then. Becky Williams, National Library of Medicine. This kind of goes back to the discussion from, I think, 2 questions ago. And the title of the panel is around, improving recruitment and retention. And I'm just sort of wondering and want to probe that a little bit in terms of how genuine that is in the context of the goal to have patients who are informed so that they can decide whether they do or do not want to participate. What really are the right metrics for ensuring that when we're talking about health literacy, we're meeting that goal of patients being informed rather than decide around sort of whether we were able to get them on the trial.
So one of the things that I've been very interested in trying to do research with the different companies that I've worked with over the years is looking at what has worked in like smoking cessation programs and weight loss programs. It's like there's 22 questions that can be asked in the clinical setting is to sort of probe the readiness of the patient that will they actually adhere to a smoking cessation program or a weight loss program. And I've often wondered from a patient perspective, why aren't we doing those same kinds of questioning like before even you get to informed consent around the concept of clinical trial readiness? Is this patient really truly ready to participate in research? Not only do they understand what needs to happen for this very specific clinical trial, but are they at a point where they understand what's needed just in general to participate in clinical research? And I don't think we do enough to really assess the patient from that kind of perspective. Are they because there's financial implications to participating in clinical research. There's time away from work. There's a whole host of things that the patient has to think about to make that decision that is never really addressed in an informed consent. I've never seen an informed consent that says, in order to participate in this trial, you're going to be away from work, 5 days a week for 1 hour, or you're going to have to take time off from work, drive into the hospital 2 hours away. Like we never really consider those kinds of questions, and I think that goes back to the context that you were talking about even before, that there's a whole context, there's a whole litany of things that go around the decision-making process that are never, I think we push too much to informed consent, and we have to sort of separate what can we do to prepare the patient before we even get to informed consent, and the education has to be continuous, and so.
And you raised the point about 22 questions, and I think about the cognitive burden to process 22 questions, and that would make me tired.
Yep.
And it could probably cause me not to participate.
Absolutely. I use that as an example. I don't
Right.
know, and I know that if you're interested in that, I'm sort of blanking on the name, but I think it was Hibbard that did a number of different research protocols around, smoking cessation readiness, and they scale it down to a 13 question at some point. So it is, but again, there's patient fatigue.
Right.
Are we looking at those kinds of factors before we even start, standing there with the megaphone and blasting out everything you need to know about the trial,
Right.
To capture a signature? So I think these are great. It's a great discussion to have and a great way to begin to look about, how do you start breaking down metrics that make sense for evaluating what the end goal truly is.
Sure. Thank you.
Absolutely, thank you.
As I think about what you said, though, part of what I heard in your question was something about the authenticity of engagement. And, what I would say is if you start at the very beginning, sort of one of the golden rules in health literacy is engage people early and often in everything you do. And if you do that, the outcomes are different in and of themselves. And so when you're talking about sort of the authenticity of this, I'm thinking people, investigators, physicians, trialists who choose to have sort of deep, meaningful engagement with materials that people understand so they can make their own informed decision, sort of by definition, are authentic in their caring. That's not sufficient, certainly all the way across the trial. You can't just stop there. But if you don't even start at that place of trying to make sure that people are informed in a way that makes sense and it's contextualized into their life. I mean, we can't possibly build all the documents in any format that would tell you that, you're going to be away from your job for 2 hours because frankly, like your job's not the same as my job, so I may not be away from my job for 2 hours. We can't create so many complexities that it becomes no longer real. But the idea of figuring out sort of what's the basic information that creates information and how do we meet the regulatory requirement to get the approvals documented, which is just necessary. But also, as Michael said before, how do we have those conversations to support that regulatory document so that we're certain that people understand and they're taught back? And to me, if you start that at the beginning and you maintain that level of communication as you go on, it creates a different partnership. I hear patients and sponsors talk a lot about what does it mean to actually be a partner in a trial? What does it mean to make patients as partners? And I think this is it. If you can make sure that every step of the way you're staying connected, you're checking standards, you're making sure that people agree, you're better off than you were before. I don't know what the metrics are for all of that. I mean, there are simple sort of counts. There's some qualitative metrics. There's the absolute result at the end of how many people dropped out versus didn't. We talk about adherence and compliance and all those sort of nasty words that are not health literate in many, many ways. But the truth is, they're proxies for how much people understand and engage and are actually into what you're doing. So I do think those metrics are still relevant here.
Okay, thank you. We have about 30 minutes. Maybe we could wrap around. I see Deborah, Patty, Terry. Did I miss anyone else in the second row? So Deborah, let's start with your question.
Okay, I have a specific comment and actually question to the panel, and then also maybe a challenge to the roundtable. So when we were talking about information and how to get information to people in different ways, and the portal came up, I just wanted to mention to that there are so many different portals that I'm hearing about from different companies and different clinical trials and different initiatives, that we're kind of creating the same issue again, that the patient is the one who then has to manage all of that. And so, getting back to one of Alicia's comments about, what it's kind of like, if we were truly patient-centric about this, we would be thinking about when a patient goes into a blood lab, for example, all of the doctor's orders that wanted something from them, and there are many different lists of doctors, would already be there. So they just have to go in once instead of having to be a pincushion, 10 to 15 different times, depending on who wants what. So it's just a different approach. And so I'm wondering what the reaction of the panel would be to that. And then I'm also really interested, hopefully by the end of the day we'll hear this, in what the roundtable is going to do with all of this information to help us actually take action and accelerate the process of getting health literacy into the clinical trial arena.
I'll start. I feel like that was a softball for me because one of the things that I've been thinking about lately is this concept of the patient is the API. The patient is the one that's responsible for taking information from either the clinical research providers back to the primary care providers. Like the patient is the one, the burden is on the patient to move information around this healthcare journey. And it drives me crazy that, I mean, 28 years into my cancer journey, I'm still hand delivering scans from one hospital to another when I have to go, if I start out at, I won't say the hospitals, hospital A, and have to share some results with hospital B, I have to hand carry those records because they're not on the same systems, they're not on, there's no way for me to email these things or just have the doctor call the other doctor. It's a nightmare. And I think that to echo your concerns about the concept of the patient portals, I feel like if you had to see the login list that I have for all the different patient portals I have, it's sort of scary because I have not been able to get all my information in one spot to be able to feel like I'm confident in going in to my doctor and sharing this information. And what's been my workaround? I've been almost to the point where I'm like stalking my oncologist and my primary care provider, and I've told them they can't retire until I retire and can follow them wherever they go because they know my story. I've made a conscious decision to stay with the same healthcare team because I actually feel that having the longevity that I've had with my oncologist and my primary care has made me healthier and safer as a patient than going from one system to another. And yes, I seek out second opinions, third opinions, and I always return to my primary care physician and my oncologist because I feel like as long as they're the sort of center of truth for my healthcare story, I feel confident in that. But I'm the API. I'm the one carrying records and connecting information sets about my journey when I need to make a decision. And I think that, my challenge back to industry is where is that central source for the patient that wants to interact or participate in trials that might be with different sponsors or different pharmaceutical companies. If I'm on a pharma company A trial and then roll into pharma company B trial, I want continuity of my clinical research journey available to all these research, not just, well, I was here at this trial and that's a data point at a very specific moment in time, and here's another data point and another very specific moment in time. And I think the challenge is, back to industry, what do we do to begin to build this framework allow for seamless information exchange and allow for a continuous educational process throughout, so that the patient is constantly learning and the physicians and the researchers are constantly learning and evolving on that journey. And it's not just one and done this moment in time. So, all right, I'll be quiet.
Panelists have a comment? Or? No? Okay, thank you. Patty?
So I'm probably reiterating because it took a while until the words kind of came out. I think Alicia was the first one that said it, but I really think that we need to really flip the paradigm of the clinical trial. And I really hate that it is trial focused. Everybody's interested in their own trial. I think I went to NCI years ago and they said, let's pick the top 10 trials. And I'm like, what? I mean, that doesn't even make sense from a patient perspective, because from my perspective as a patient, what's best for me is what I want to know, not if I fit your trial that you're pushing on me. If I fit that, it's about me, it's about the patient. So really flipping that dogma over and saying, once you're a patient and in a system, then you talk to the patient about clinical trials, just like Alicia said, and it's a partnership where you build a relationship. And then it's what trials are best for that patient, not which trial are you pushing today, you know, type of thing. And I think that kind of like the blood sample thing, I love that, you know, like the patient should go in and the clinician should know what trials that patient might be eligible for. But in talking to the patient, what trial would be best for that patient is what we really need to get to. But that's a communication that needs to go on. And I think that that's where the partnership is, and that's where the first information about clinical research can go to that patient, and then you can tell whether they're ready for it or not. But really, it's a partnership and building relationships. And also, I think what we haven't really touched on a lot is there's a lot of different people involved with this process. It's not just us in the room. It's not just the patient. It's the clinical research professional. It's the clinician. The number one reason why patients go on clinical trials is their physician asks them to. And so I think those are things. And then also, as Deb was saying, really this all sounds really good, but in implementation is really hard. I mean, I've been doing it with Deb a long time, and we've, you know, how you retain patients or the endurance of patients, you know, whether you do newsletters or different things or have gratitude. My dad got a thank you letter for being on a trial. Just trying to get that instituted is like nightmare. And so, you know, what are those barriers to implementation? I think we really need to address those as well at this meeting.
Thank you. Ebony, did you have something you wanted to say to that? Okay, thank you. Terry?
Patty and Alicia, I want to tell you from some focus groups that Connie Arnold and I did on clinical trials and people's understanding and acceptance and trust in them. It all went back to the relationship. The trusted, long-standing relationship with a primary care provider. We found out from CRAs that trust in the clinical research assistant was also important. And one of the things that I'm thinking, I don't know if the Health Literacy Roundtable can do this, Larry, based on what you said, we need to do a better job of getting feedback. So when you go back to your primary provider for your diabetes or hypertension or whatever else you're going back for, he or she can say, how's that study you're on, that cancer study you're on or whatever, so they can continue to be a part of that. You know, we try to put everything out on the internet or something, but it's like in these portals, but it's like the relationship is so key, especially if you're frightened or uncertain about something. So that was one thing. And then, Katina, I had a specific question to you. In research that Mike and I did with tables, with trying to simplify labels and tell people what time to take medicine, people with low literacy had trouble navigating the table. I love the color coding, but did you find people could handle the table?
So there were a bunch of iterations in this thing. So we took the way that this worked is we took a consent form as it was written, and they tested it with over 100 people. And we sat behind the window and we listened to all the things they said and all the problems they had. And then we took it away and we rewrote it. And we came back with this rewritten version with the tables. And they did another set of about 10 focus groups, and they had over 100 people. And they really got into the minutia of how to help them read the table. And honestly, like with every new group, there was another set of sort of iterations of like, it doesn't work if you do this, but if it works if you do this. And what about if the lines are heavier and the spacing is more and the font looks like this? And they really were very specific about what made the table useful and usable for them. And so I think that goes back to a lot of the conversation that we've had. I think there are some big lessons that we can take away from people about the use of graphics and tables and color and charts and lines. But as we are still learning, I think we have to really use people's participation to test every one of these things. I don't think there's a standard application that you can just plop out and tell people that this will always be okay. I've not heard that anywhere. And so I don't disagree at all. As the population changes, again, how many more words? What about the icons? All of that stuff comes into question.
I just wanted to comment on the primary care provider comment. As a general internist, I would say that primary care providers are often left out, often mentioned as being a key part of this, but also often left out of the equation. And so you find out that your patient is enrolled in a clinical trial. You have no information about the clinical trial. Patient may come to you and ask you about it, and you are trying to help the patient navigate a number of issues in addition to deal with that clinical trial. So I do think that if the primary care provider becomes a focus, it has to be really thoughtfully well done, and that many primary care providers also need some literacy training in clinical trial and what that means and what they are and what their responsibility would be and how they can help the patient with that trial. So I'm always excited to hear the primary care provider mentioned, but also cautious that we don't say, okay, the primary care provider can do that, and don't arm the primary care provider as well to partner with patients to help with those trials.
So a lot of the primary care providers we were listening to were in federally qualified health centers. They said they didn't have time to go on the internet to look for clinical trials that would be appropriate. Also, the rural providers they don't know the academic researchers. So that relationship is missing. And if we want primary care providers to help us, we've got to make it easy for them to find out about appropriate trials to mention to their patients. And we need trust is everywhere.
Precisely.
And I think those primary care providers need health literate information that they can share with their patients, because they don't have time to necessarily explain it all.
They don't want to consent them. They don't have time
Right.
to go in the weeds about it. They just
Exactly.
need a brief talking point.
And then the other thing that sometimes happens is that results of a trial come out, and some of them might be a bit startling, and there's no warning given to the primary care provider. So a patient may stop a particular drug or change drugs and not having talked to their healthcare provider. Larry, you had a comment?
I guess my comment is that my experience as a physician is that if you treat a symptom and not the diagnosis, sometimes people transiently get better, but they never really get better. And I think the diagnosis here is not the uninformed patient. It is a lack of trust and a lack of face-to-face time with that patient. Those are to me, the two things that are the disease that results in the uninformed patient. And if you don't start with trust, nothing happens. And then if you think you can hand somebody anything, even the most beautiful diagram, and not sit with them, you're kidding yourself. And to me, that's the diagnosis, and the result of that diagnosis is people having enormous problems understanding, and therefore not having trust, and therefore not enrolling in clinical trials or dropping out when anything that frightens them and breaks that very superficial trust happens.
Yeah, I mean, I would say when we're creating all of these documents, our intention is not that you hand it to somebody and they're done. I think the point is that you can have a structured conversation around whatever document You have something that people can look at. If you talk your way through what it means, then they can walk away and have enough of a sort of memory crutch that they're able to talk about it again. And if we don't give them any visuals, we don't give them anything they can sort of hang their information on, all they've got are words that are too big and too complicated and too scary. And so I think that's what some of this health literacy best practice does, is it creates an easier to use, nicer form and nicer material. But yeah, I mean, at the end of the day, if providers had the time to do all of this without the forms, that'd be great, right? If everybody could do that and we could record the process and we can just sign off in a chart that the person is consented, I think we would rethink gold standards. But I think we know that that's not going to happen because the providers have such limited time. And honestly, from an ethical perspective as well, if it's completely verbal with your provider, the obligation on the patient side to do what your provider asked is so heavy that's a problem too. So all of these forms of materials are supposed to give you some space and some flexibility and some real support. They're not the be all to end all.
I think I'd like to just add, from sitting here today, I think, how many times have we heard the term speed, efficiency, cost, time? We're talking about these concepts. Everything's a race. We're in a race for the patient signature on informed consent. We're a race to bring a new drug to market. We're in a race. Speed. It's got to be faster. It's got to be cheaper. It's got to be done yesterday. And what we're talking about is we have to stop, take time to build these relationships, take time to process information. For me, on my cancer journey, I learned very early on that if you're going to present information to me, I have to be able to have time to walk away and process it. I can't make a decision right then and there. And the system, the way that it's built, it's about speed. It's about making decisions in sort of this rapid fire mindset. And everything today is about consuming information as quick as possible and moving on. And what we're trying to do, or what we're asking of the system today, is to slow down and allow for these relationships to build. And it's very, very hard because it's almost counterintuitive. We're setting up these friction points all over the place because we can't get to that sort of sweet spot where we need to be, where the journey has to take a little bit longer to get to the educational nirvana, I guess, if you will. But and I want to go back to the point that you were making earlier. Another thing that I've been sort of fascinated with in talking with patients over the last few years is this concept of clinical care versus clinical research. And they're sort of set up as competing interests sometimes, or you've got clinical care over here and clinical research is over here, but there's no information exchange or like bridge between these two. And if you're in the clinical care side, your hat and your vision is very focused on the care, delivering care to the patient at that very moment. And if you're focused on clinical research, you're looking at the end goal of, does this therapy work or not? And it's not, but the patient sort of sits in the middle and thinks, well, I don't look at this as clinical care. I don't look at this as clinical research. I look at this as healthcare, or I look at this as somebody's taking care of me or helping me get better or stay well. And those are two very different mindsets that we're asking to begin to converge in some ways that I don't think we ever thought about before. And our systems aren't set up for that. Our technical systems aren't set up for that. The mindset and the way that we engage with healthcare is not set up in that way. And I think we can go a long way in helping patients understand that there are subtle differences between these two worlds, but let's find a way to begin building bridges that allow for the healthcare journey to be as seamless as possible for that patient. And I think that we've got the tools, we have the technology. It's about building the relationships at this point that gets us from point A to point B in a way that makes sense for all of us. So.
You had a number of thoughts. I like these discussions because it helps me spark my thinking and think about things in a different way. Regarding what you just said, Alicia, the trust that we've been talking about, and how can we do this from a from an institutional level, because I think researchers or, PIs, they tend to think about their research, but yet institutions can really, figure out how they can build their trust. I think about our institution, our Translational Research Institute, and the CTSAs around the country. Taking it from clinics, from research to clinicians and all of that, that could be something where we focus more of our research on, is how do we build that trust, long-term trust, not just for this one particular trial, but to others. Now, to Dr. Smith's point, about the consent being a process, it made me think about the EMA has one of the regulations requires a conversation. We don't really have the specific requirements here, but it's just kind of one of those that you do, because IRBs kind of usually, want you to have those conversations. It's a good thing, and we definitely do it. But that made me think of the EMA regulations actually requires, not only in addition to the different things you need to consent about, but that you have this conversation and not just be in writing. I think that's, but again, that's kind of the nice thing about having the conversations. It helps you build that trust and connection, and it's not just this, here's these words that were probably written by somebody else and approved by somebody else. This is, this is the two of us talking, or the three of us, or whatever it is, if there's a caregiver there. And it makes me think of a quote that I use in some of my talks sometime. I usually show this quote by Charlie Sheen. He says something, it's a long thing. It says something like, "You can't process me with a normal brain." And I tend to liken research consents to that, because there's 18 things under the Revised Common Rule that you may have to tell people, depending on the circumstances of the study. And so, as Patty mentioned, how do you process that with a normal brain? We shouldn't be thinking about this as one document. We should think about this as maybe, let's talk about the study, sign. Let's talk about the risks, sign, in different conversations. I mean, it might not be something you can do logistically, for low-risk studies or low-dollar studies, but for the really high-risk, first-in-human studies, this seems something that just needs to be, embedded into the culture of what we do, is we take people along this educational process. And we have, if the lawyers need signatures, if my type needs signatures, that's fine. We get signatures on different days and for different sections and those type of things.
Okay, thank you. I see quite a few cards up, but you're waving yours, so I guess I'll let you do one. Then maybe Jay.
I'm Phyllis Massey with the Huntsman Cancer Institute, and one of my charges is clinical trials for There we go. Phyllis Massey with the Huntsman Cancer Institute, and part of my charge in my program is to do outreach to rural frontier populations, and that includes American Indian, Alaska Native farmers, ranchers, polygamists, Hutterites, miners, everyone who's out there. And part of the problem is, I don't hear mentioned a lot of, is the PCP, the primary care physician. And that is a large component of health literacy, is your PCP, one. And two, the other part of this is something that I incorporate is in health education. It's not just about cancer when I speak, because there's comorbidities that we deal with. But health education also includes clinical trials, it includes screening, it includes every aspect along the continuum of what is included when we, as patients, when we become patients, or our family members become patients, so that's part of the vocabulary, because you can't ask for something if you don't know about it. And so if we also take the time to kind of restructure how we do how we speak about clinical trials to a health education continuum, and you start that education as just part of the process, because one of the things I say is, do you remember Jimmy Carter? He was part of a clinical trial, and he's still out there building houses, and they see it, and so it's part of the marketing too of what that clinical trial did. So there's components I think that we're not touching on, and I'm not hearing.
Go ahead, Alicia.
I think what, the concept that we really have to start thinking about is moving our system of healthcare from reactive to proactive. And we're not doing that enough. And every healthcare interaction I've had since I was 19 years old has been reactive. in nature. From the very first moment I was diagnosed with cancer, there was no proactive aspect of my healthcare journey. It was just, it's been reactive ever since. And I think the way that the system is set up, it's all about reaction to a problem. And we have to shift the way that we think about healthcare to be much more proactive in order to really truly achieve, this concept of seamless healthcare. It's just we can't continue to work in the reactive mode and try to roll things out in that way without changing the way that we look at what we have to do.
Okay, thank you. Jennifer, I know you have a question. We've got 4 minutes left, so, okay.
So this is Jennifer Dillahay. We've been talking a lot today in this panel and stuff about what you might think of as the health literacy of the system and how we struggle with addressing the needs of patients who may have low health literacy. But what if we viewed clinical trials as an opportunity to support the patients to increase their health literacy? So it seems to me a clinical trial would be a wonderful opportunity to coach patients, empower them, and those kinds of things would develop trust. And so by the time the patient finished the clinical trial, their health literacy skills would be much more robust than when they started. And and we've kind of talked about that a little bit. We've kind of skirted around the edges, but I just think that we're missing a really great opportunity with the clinical trials if we don't do that.
Okay, thank you. I appreciate that comment, and I think we want to be sure that we don't make the participant in the trial feel as if they have an inadequacy too, because we have the responsibility. And there's someone else who had a question in the back. Okay.
I need to stand up because I'm vertically challenged. Thank you guys so much. Thank you, this panel, everybody who's going to be speaking today, and to the National Academies for bringing this together. Such an important topic. A lot of folks have talked about how many challenges there are. There's so many layers and such far-reaching sort of implications, different stakeholders. But specifically, if I can ask for you guys to talk about some of the challenges in really engaging patients in the community effectively, appropriately, given that we have all of these challenges, right? I mean, a very good point. We could utilize clinical trials, and we have, right, in a way to educate patients. But is that really the responsibility of researchers? I say it's a responsibility that the industry can take on. But who else has responsibilities? And given all of the operational issues, the operational challenges, that's really what I'm hoping to hear a couple of sort of just insights, maybe examples, things from industry, from academia, from practitioners, how you guys have worked to incorporate patient voices and community voices in a way that respects them and actually adheres to and tries to help out with those issues that they've voiced. The reason why I say this, and by the way, my name is Betosh Bahadur. I'm with a nonprofit called SysGrip. We've been working in the space for a long time. We provide clinical trial results summaries. We have worked on informed consent documents. And I think that one especially gives a really good example that Professor Trudeau has pointed out. That initial section of informed consent, essentially the guidance says you need to figure this out on a case-by-case basis. How can you do that if you don't engage the community and patients for each and every study? We do patient advisory boards on protocols and things of that nature and the materials and studies, and it's really great to see sponsors engaging in that way, but it's certainly not for every single trial, and it's hard to do. Operationally, like everybody has said, these trials need to move along to bring medicines to the public as fast as possible. One day we will get to a place where it's fully integrated, but up until then, what have you guys experienced? How have you addressed these operational challenges?
In the academic realm, and this is really speaking as an NIH-funded investigator, there are a lot of issues around resourcing for this, and that, the resourcing for the trials, typically the trial funding starts, and you're supposed to be enrolling participants right then and there when you get the money, and there are really very few mechanisms that provide for this pre-trial work that needs to be done. In the academic realm, the CTSAs, which do support community engagement course, provide some of that, but they're still very underfunded. And like, for example, I'm the director of our CTSA at Duke, our Clinical and Translational Science Award, and our community engagement course is actually our largest core. It requires the most people, the most time intensive, but there's a huge range of things that we're being asked to do. So as from the standpoint of an investigator that does NIH-oriented research, I would say the entire mechanism of funding needs to change to accommodate this type of engagement that would happen before a study is funded, at the time the study is funded, and after the study is funded for this whole communication piece.
So all of my work before I got to health literacy was community engaged research, CBPR, and all of those models. And a lot of people do it well, right? And they get funded to do it well in those areas because that's part of what they build and they budget differently for it. I don't think that we've converted that to sort of the larger industry, and we've really embraced all of those components. But it's not impractical to, and I think that's what a lot of the advocates are asking for, is they want to be included before a trial is even funded. They want to think about the research questions. They want to be engaged beyond just the question, but how do you actually do this logistically, and how, there's certainly a statistician that tells you how many people and all these things, but like, is that feasible and is that reasonable, and should we do this to all these people, and why are we going to do this, and what does that mean? So I think all of those models from CBPR can come over and be more broadly utilized, and they're not. It's uncomfortable and it's complicated, and it also is a real challenge to the scientific model that a lot of people grew up in. So you have to sort of recalibrate what you think is normal and fair and real. But I think that it works. And then certainly, we're doing much of the same work that you're doing. I think in terms of the patient boards versus individual interviews and how do we test these things, I think you have to be really thoughtful about what your intention is and what your audience and purpose is. It is just a show if you have a board to come and answer a question that you already know the answer to. We don't need a board for every single trial. We probably do need boards for sets of conditions. So if you have a disease focus area, there's probably a board that can answer a lot of questions about that. But at the trial level, perhaps 5 or 10 people can give you what you need to know. And there's some interesting results from some other health literacy folks presented at a session a couple of years ago that showed that 85% of issues can be found from about 5 people. I mean, it really doesn't take that many people to get this right, but we build these really complicated infrastructures so that we can say we've done it and people feel like there's enough something to do it right. And I think we need to really rethink that and think about how we partner, how we use what we already have, and how we go to audience and purpose always to address the intent.
But I would like to thank my esteemed panel members and all of you in the audience for a great discussion today. People will be around during lunch if you have more conversation. We need to be back in this room at 1:15. Thank you.